Welcome to the Deep Dive. We take your stack of information and, well, we really dig in to find the fascinating stuff. Today, we're looking at something incredibly personal, something universal, really. How our faces and skulls actually grow. That whole intricate journey from the very first moments of life, way before you even take a breath, there's this biological symphony, conducting how your face and skull form. We've got a pretty comprehensive stack here. It unpacks human morphogenesis, prenatal, postnatal growth, all the factors involved, and even clinical treatments. Think of it like a roadmap, helping you understand why every face is so unique, and maybe what happens if that map has a few detours.
Yeah, and what's really striking is just how complex and frankly delicate this whole process is. We've learned a lot, obviously, made huge strides, but the precise biological triggers, the mechanisms controlling growth, still a lot to investigate there. So we'll be exploring, from those first cells differentiating right through to how faces change in adulthood and why nailing down this timeline is so critical for doctors and surgeons.
Okay, let's dive into that journey then, starting right back at conception. Our sources split this into two main periods, right? Embryonic and fetal.
Exactly. The embryonic period first, that's fertilization up to the end of the 8th week. This is where the real blueprint gets laid down. You start with the single cell, the zygote. It divides again. 4 divisions give you a 16-cell morula. That quickly becomes a 100-cell blastocyst, which implants in the uterine wall by the end of week 1.
Wow, so fast.
It is. And then by week 3, you've got this embryo organizing into 3 basic tissue layers: ectoderm, mesoderm, endoderm. These are your building blocks. Things like your dental enamel, your oral mucosa that come from the ectoderm. Connective tissues, muscles, that's more the mesoderm.
And while that's happening, the nervous system's starting up too. Neurulation, is that it?
That's it, formation of the neural tube, the very start of your central nervous system. But yeah, for the face, something else really amazing happens around week 4. This population of cells emerges the neural crest. Truly remarkable cells. They're multi-potential, meaning they can become many different things, and they migrate all over the embryo.
Right.
In fact, pretty much all the bone and connective tissue in your face and neck comes from these cranial neural crest cells. The only exception is dental enamel. They turn into tooth-forming cells, bone-forming cells, osteoblasts, cartilage-forming cells, chondroblasts, you name it.
So they're not pre-programmed.
That's the key thing. Their fate isn't set. They get instructions from the tissues around them as they migrate. It's this incredibly sophisticated dance, cell communication.
So these neural crest cells are like sculptors. What are they sculpting?
Good analogy. They migrate and form structures called pharyngeal arches. Most of your head and neck bits come from these arches. From the first pair, 5 main facial bumps, prominences emerge. A single front and nasal one for the forehead and nose, and then paired maxillary ones mid-face and mandibular ones your jaw.
And these bumps, they don't just sit there, right? They grow and fuse together.
Exactly. They actively grow and merge. The mandibular ones fuse early, forming your chin and lower lip. The front to nasal one gives rise to nasal placodes, I think of them as patches, which then form medial and lateral nasal prominences. The medial ones merge, creating the middle part of your upper lip and the primary palate. Then the maxillary prominences join in, merging with the nasal ones. That finishes the upper lip, sets the width of the mouth, all by week 6.
That merging sounds crucial. What if it doesn't happen right?
Yeah, if that process fails, the breakdown of the surface tissue and the underlying cells joining up, that's when you get facial clefting. And lots of these steps are controlled by signaling proteins. Sonic hedgehog, SHH, is a big one. Mutations there can cause really severe midline problems, cleft lip and palate, sure, but also things like holoprosencephaly. Holoprosencephaly. It's where the brain doesn't divide properly into 2 hemispheres, so SHH is vital.
Right. It sounds like there's so much potential for things to go slightly off track. Our sources really emphasize how much mouse studies have taught us here.
Oh, absolutely. Gene targeting in mice has been huge for understanding normal and abnormal development. Like those SHH mutations in mice, they can cause cyclopia, a single eye. In humans, it's more often holoprosencephaly. We've also linked specific genes to specific syndromes. TCOF1 with Treacher-Collins syndrome that affects facial bones, tissues. FGFR1 with Pfeiffer syndrome, which involves craniosynostosis.
Craniosynostosis, that's the skull bones fusing too early.
Exactly. So yeah, genetic mapping is rapidly pinpointing the molecular causes for a whole range of these craniofacial differences.
Okay, so we have these initial structures, these migrating cells. How does it all turn into actual bone? Face, skull?
Right, ossification. bone formation. It kicks off in the late fifth week. It's guided by major signaling pathways, one SHH again, BMPs.
VMP?
Bone morphogenetic proteins, really important for bone growth. The flat bones on top of your skull, the cranial vault, they come from membranous tissue. But the bones at the base of the skull, the cranial base, and the facial bones, mostly from those neural crest cells again.
And when do we see the very first signs of actual bone?
Earliest signs are around weeks 7 and 8, though the mandible, the lower jaw, actually starts a bit earlier, around week 6. You start with tons of these little ossification centers, but by birth, they've formed about 45 distinct bones, which eventually fuse down to the 22 bones we have as adults.
Okay. And you mentioned the primary palate earlier. What about the rest of the roof of the mouth?
Ah, the secondary palate. That's one of the last things to finish up in the embryonic period.
Oh.
You have these paired shelves growing from the maxilla, the upper jaw. Initially, they point downwards, and your tongue is actually sitting between them.
Really?
Yeah. Then, as the tongue moves down, these shelves flip up, move towards the middle, and fuse together. That happens between the end of week 8 and week 9. TGF3 is a key protein involved in that fusion process.
So end of week 8, the blueprint's basically there. The main structures are formed. Then comes the fetal period, week 9 to birth. What's happening then?
Growth. Mostly growth and expansion. You see this clear cephalocaudal gradient.
Cephalocaudal, head to tail.
Exactly. The head grows faster earlier, so at 9 weeks, the head is like half the fetus's length. By birth, it's down to about a quarter. Still big, but proportionally smaller. And there's a big growth spurt prenatally between 20 and 30 weeks. The brain especially grows incredibly fast. This rapid brain growth is actually what makes the neurocranium, the brain case, so dominant early on. At birth, the ratio of neurocranium to face is still something like 8-to-1.
Wow. How does that affect the face itself during this time?
Well, the facial bones grow more in length, front to back, than they do in height or width. The exception is the mandible, the lower jaw. It grows more sideways, transversely, to keep pace, to articulate properly. Those ossification centers keep getting bigger, and by about 14 weeks, most facial bones have their basic shape and start remodeling. You get bone added to the front of the maxilla, mandible, cheekbones, the zygoma to make space for the developing tooth buds.
And what about sinuses? Teeth?
The sinuses start developing. The maxillary sinus begins its hollowing out process, pneumatization, around 5-month gestation. And by 16 weeks, the germs for your permanent teeth are starting to form, with the first permanent molars showing up at the back of the jaws.
Okay, so the baby arrives. But the face is definitely not finished growing. How do we think about what's driving that postnatal growth?
Yeah, good question. We often distinguish between growth centers and growth sites.
Oh.
Growth centers, like the cartilage junctions in the base of the skull, the synchondroses, seem to have more built-in intrinsic genetic control. Their growth potential is sort of programmed. Growth sites, on the other hand, are more influenced by outside factors, functional things. Think of the jaw joints, the mandibular condyles, or how sutures respond to forces.
So the top of the skull, the cranial vault, that's still changing quite a bit after birth.
Oh, absolutely. At birth, those skull bones aren't fused. You've got the sutures, the gaps, and the fontanelles, the soft spots. That allows the skull to compress during birth, which is pretty handy. Those fontanelles usually close up in the first couple of years. But the brain keeps growing rapidly. That expanding brain puts tension on the sutures, and that tension stimulates bone growth at the edges.
Which explains craniosynostosis again, if a suture fuses too early.
Precisely. The brain keeps growing, but the skull can't expand properly in that direction. It causes deformation, can even impact neurological development, often needs surgery early on.
And the cranial base.
Yeah.
Underneath the brain, you said that's more stable.
Relatively stable in its shape, yes. Seems largely genetically set, but it still grows. There's a key junction, the spheno-occipital synchondrosis, that keeps growing into adolescence. It's a major driver of postnatal base growth. And that prolonged growth is really important. It allows the maxilla, the upper jaw, to grow backwards properly, make space for the airway behind the nose, the nasopharynx.
And if that doesn't work right?
Well, a classic example is achondroplasia. That's a mutation in the FGFR3 gene. It affects cartilage growth, including in the cranial base, and that leads to underdevelopment of the midfacial hypoplasia.
Okay, so cranial base growth influences the midface. How else does the midface and nasomaxilla grow after birth?
It keeps moving, essentially, displaced downwards and forwards, partly pushed by that ongoing brain and cranial base growth, but also influenced by the growth of the nasal septum. The maxilla itself grows vertically through growth at the sutures connecting it to other bones and also through remodeling. Bone gets resorbed or removed on the nasal side and added, deposited on the oral side, the roof of the mouth. That makes the whole structure move downwards.
And all this creates space.
Creates space for the airway, the nasopharynx, and importantly, for the permanent molars to erupt at the back.
Right. And the mandible, the lower jaw. You said it's the late bloomer.
It really is most delayed and longest period of growth of any facial bone. It's often a bit set back, retrognathic at birth, but then it usually catches up with pretty rapid postnatal growth. And its growth is super dependent on function. Muscle activity, where your tongue rests, chewing forces, all play a role.
And it keeps growing longer.
Yeah, what's unique is the cartilage at the condyle, the jaw joint. It never fully turns to bone. It retains growth potential throughout life, unlike most other growth cartilages. And how it grows, its rotation, really affects your facial profile. A forward rotation usually means a deeper bite. A backward rotation can lead to an open bite at the front and maybe a smaller lower jaw.
And it has that puberty growth spurt.
Big time. That's when it often really catches up with the maxilla.
And while the jaws are doing all this moving and growing, the teeth are coming in too.
Right. And the bone that holds the teeth, the alveolar processes, that's a big contributor to your lower face height. But that bone is entirely dependent on teeth being there. If you lose teeth, you lose that bone. Primary teeth start emerging around 6 months. Permanent teeth are mostly in by 12 to 14 years old. And how those teeth erupt is closely tied to the facial growth pattern. You see different eruption timing in, say, class 2 versus class 3 jaw relationships.
It's not just the hard tissues, the bone, though. The
Yeah.
soft parts of the face must change a lot, too.
They absolutely do. The soft tissues follow the bones generally, but not perfectly one-to-one. In childhood, you have more subcutaneous fat, so the profile looks more convex, more rounded. Lip thickness changes over life. The nose keeps getting bigger and more prominent well into adulthood, and the face matures in sections almost. The upper third, forehead area, finishes growing earliest, maybe around 12. But the middle and lower thirds keep going well into puberty, sometimes beyond.
And the overall proportions, how do they shift?
Generally, width finishes first, transverse growth, then length, front to back, anteroposterior, and finally height, vertical growth, though, like we'll discuss, they all continue subtly into adulthood. As babies, our faces look really wide compared to their height. Then as we get older, especially males, the profile tends to flatten out a bit, nose gets more prominent, chin gets more prominent, lips look less full or retrusive, and males generally just have more growth for longer, bigger changes overall.
Okay, so this idea that growth just stops dead after puberty, that's not really the case.
Not at all. That was one of the big surprises from long-term growth studies, late 20th, early 21st century. Growth does continue into your 30s, 40s, maybe even 50s or 60s. It's much slower, obviously, and the changes are smaller, but it doesn't just stop.
So the face literally never stops changing.
Pretty much. Subtle increases continue in all 3 dimensions. Vertical changes are usually the most noticeable, then front to back, and width changes the least. That head-to-tail gradient continues too, so the mandible tends to change more than the maxilla, which means jaw rotation, tooth eruption, that can persist. Females, for instance, often show a bit more vertical growth and backward mandibular rotation into adulthood, whereas males might show more forward rotation, which can actually make their profile look straighter over time.
And the soft tissues as we get older.
Oh, the soft tissue changes in adulthood are actually much bigger magnitude-wise than the bone changes. Lips tend to get thinner, less prominent. The upper lip can lengthen vertically. The glabella between the eyebrows moves forward and down a bit. Your nose and ears keep growing. The tip of the nose often drops, making that angle between the nose and upper lip sharper than nasolabial angle, more noticeable in men. And then you get the classic signs of aging due to loss of elasticity, deeper nasolabial folds, jowls, corners of the mouth sagging. So if you're listening, the takeaway for orthodontists and surgeons is they have to factor these lifelong changes into treatment planning. Sometimes the goal is to actually increase dental or skeletal volume a bit to help support the soft tissues, keep them tighter, maybe avoid treatments that could worsen aging signs like deep folds or a loss of lower face height.
Right. It's a lifelong picture. So with all these incredible changes happening over decades, what's actually controlling it all?
That's the million-dollar question, isn't it? It's super complex. It's this intricate mix of genetics, epigenetics.
Epigenetics. Those are changes in how genes work, not changes to the genes themselves.
Exactly. Changes in gene expression. So, genetics, epigenetics, and local environmental factors all interacting. Genetics is definitely the main driver, multifactorial genetic control. But untangling it from the other influences, almost impossible sometimes.
We touched on things going wrong early on, prenatally. What are the main categories of problems there?
Broadly, three types. First, malformations. These are problems baked into the developmental process itself, often genetic or maybe caused by a teratogen.
A teratogen being.
Something harmful the mother is exposed to, like certain drugs or infections, especially during that critical embryonic period. Second, deformations. These are caused by physical forces in the womb, intrauterine pressure squashing things, basically. And third, disruptions. This is where something external interferes with the developmental process that started out normally, also usually during the fetal period.
And that early window, weeks 4 to 8, is super critical.
Extremely. That's when those neural crest cells are migrating like crazy, the facial prominences are forming and fusing. A lot is happening. Genetic issues can range widely. Chromosomal abnormalities like Down syndrome often lead to midface deficiency and anterior open bite. Single gene mutations cause specific syndromes we mentioned, like Treacher-Collins. Facial clefts are relatively common malformations. Unilateral cleft lip is about 1 in 700 or 800 births. And you can have really severe conditions like agnathia, complete absence of the lower jaw.
And environmental factors. They can have a huge impact, too.
Huge. Maternal health is key. Malnutrition, metabolic problems like diabetes, infections like rubella. Exposure to teratogens, alcohol is a big one. Fetal alcohol syndrome affects maybe 1 in 750 births in the U.S., causes midface deficiency. Tobacco smoke, certain medications like retinoic acid. And the timing matters. Exposure in those first 8 weeks, that's when major structural defects are most likely. Even just physical pressure in the womb can cause deformations, like the Robin sequence. It's where the mandible is constrained, maybe pushed back. This forces the tongue up and back, physically blocking the palatal shelves from fusing, so you get an isolated cleft palate.
Wow. Okay, so that's prenatal. What keeps shaping the face after birth?
Again, genetics are still a big piece of the puzzle, but this is where environment and epigenetics really come into play interactively. Skeletal traits like jaw size and shape tend to be more heritable, more strongly influenced by genetics than dental traits like tooth position. We know malocclusions, bad bites have become more common over the last century or so. That's probably not just about mixing ethnic groups. It's likely a complex interplay of factors, including environmental ones.
Like what kind of factors?
Well, the functional environment, how we use our faces, breathing patterns, mouth breathing versus nose breathing, chewing habits, even just how you hold your jaw and tongue at rest. These neuromuscular behaviors are really important. Think about chronic pressure, like thumb sucking. If a child does it consistently for hours a day, it can actually change the shape of the jaws and position of the teeth in that area. The size and strength of your chewing muscles can influence bone shape, too.
And things like injuries or medical issues.
Definitely. If a child has surgery for something like a cleft lip and palate, the scarring can restrict subsequent mid-facial growth. Trauma is a big one, especially fractures of the mandibular condyles, the jaw joints, in kids. That can lead to stunted growth, asymmetry. Endocrine problems, hormones are major regulators too. Not enough growth hormone. Delayed facial development overall. Too much growth hormone, like in acromegaly. Bones get bigger, features become prominent. The jaw might even start growing again in adulthood.
What about basic nutrition?
Absolutely fundamental. Malnutrition is a huge cause of growth failure worldwide. It affects skull size, proportions, everything. And surprisingly, even psychological factors. Chronic stress or emotional deprivation in childhood can actually suppress growth hormone release, mimicking a physical endocrine disorder. It can be reversible, though.
That's incredible. So bringing all this amazing science into the clinic, when doctors are deciding whether to intervene, especially with a growing kid, what's the most important thing?
Assessing their stage of physical development is crucial. We see this secular trend, kids maturing earlier than they used to, especially girls. So sometimes for girls, you might miss the window for effective orthopedic treatment, trying to modify growth. For boys who mature later and grow longer, you might start treatment too early before their main spurt. And a really key point, orthognathic surgery, jaw surgery, it corrects the existing problem, but it doesn't change the underlying growth pattern. So often, it makes more sense to wait until growth is essentially complete before doing major surgery.
How do clinicians actually check how much growth is left?
Well, the traditional method is hand-wrist x-rays. You look at about 30 different bones in the hand and wrist, and they ossify, turn to bone, in a fairly predictable sequence. That gives a measure of skeletal age. More recently, orthodontists also look at the neck vertebrae, the cervical vertebrae, on the standard head x-rays they take, lateral cephalograms. There's a maturation sequence there, too.
But can these predict exactly what will happen?
That's the catch. They give you a general idea of maturity level, but they can't accurately predict the amount of growth remaining or exactly when it will happen, or even the direction for a specific individual. The most reliable way to know growth is minimal, taking repeated head x-rays over time, serial cephalograms, and seeing very little change.
Okay, so the big question in orthodontics, can we actually change how the face grows? Modify it?
Ugh, the million-dollar question again. Debated for over a century. The current thinking, the consensus is yes, clinically significant orthopedic change is possible, especially for mild to moderate skeletal issues, and especially when there's still substantial growth happening. But predictability is tough. It really depends on the patient being compliant with wearing the appliances and the specific type of problem you're treating. Early treatments were often tooth-borne, meaning the forces went through the teeth, so you often got unwanted tooth movement along with any skeletal change.
Okay, let's break it down. With problems first, like a narrow upper jaw maxillary constriction. Since width finishes growing earliest, you tackle that early.
Generally, yes. Maxillary constriction is pretty common, maybe 5% of the U.S. population, usually treated with things like rapid palatal expanders, RPEs. These put force on the mid-palatal suture that seam down the middle of the palate to physically spread it apart and widen the maxilla. It works best in younger kids, before puberty ideally, because that suture is more open, more patent. You usually have to overcorrect a bit because there's always some relapse, some springback.
What if the suture is already fusing, or in older teens?
Then a simple expander might just tip the teeth outwards instead of moving the bone. In those cases, or for severe constriction, you might need SARCI,
SARP.
surgically assisted rapid palatal expansion. The surgeon makes small cuts in the bone to help the suture open when the expander is activated, ensures you get real skeletal widening. And now there's growing interest in using TADES, those temporary skeletal anchorage devices, mini screws or mini plates. The idea is to anchor the expander directly to the bone, not the teeth. Might get purer skeletal expansion, less unwanted tooth tipping, maybe more stable results. Still relatively new, but promising.
Okay, what about front to back problems? Class 2, lower jaw back or upper jaw forward? That's really common.
Very common. Treatment approaches have been around a long time. Headgear, for instance, used since the late 1800s. Different types apply forces to the upper jaw, the maxilla, trying to hold it back or redirect its growth downwards and backwards. Then you have functional appliances, things like activators, Erbst appliances. These posture the lower jaw forward. The theory is this might stimulate extra growth at the condyle, the jaw joint.
And do they work?
Well, they can both create changes. You see short-term skeletal improvements and definitely changes in tooth position, dental alveolar changes. But long-term studies, good randomized trials, comparing early treatment in young kids versus just one phase of treatment during the teenage growth spurt. They haven't shown a major long-term skeletal advantage to starting early for most Class 2 cases. It doesn't seem to significantly reduce the need for extractions or jaw surgery later on compared to just treating during puberty.
Interesting. What about the opposite, Class 3? Upper jaw back, lower jaw forward, prognathic.
That's often trickier orthopedically. Historically, people tried chin cups to hold back the lower jaw growth. But studies showed they mostly just tipped the chin down and back, redirected growth vertically, made the face longer, and weren't very stable long term. The most effective appliance we have for orthopedic class 3 correction is the protraction headgear, or face mask. Came about in the 70s. This pulls the upper jaw, the maxilla, forward and slightly downward. It distracts the sutures connecting the maxilla to the rest of the skull.
Who's the ideal candidate for that?
Usually younger kids, typically under 8 years old, with a mild skeletal class 3, maybe a shorter face height. The problem is, after age 8 or so, those circummaxillary sutures start to fuse up, become more resistant. So the face mask becomes much less effective at moving the bone.
Is that where those bone-anchored methods come in again?
Exactly. There's a newer technique called BAMP, bone-anchored maxillary protraction. Uses minute plates surgically placed on the maxilla and mandible as anchors for elastics that pull the maxilla forward. Early results look really promising. Seems to get significant forward movement of the maxilla itself without the dental side effects you often see with conventional face masks and with better control of face height. It's a potentially big step forward for class 3 treatment.
Okay, last dimension. Vertical problems. Too much face height, like an open bite, or too little. These sound tough.
They often are the hardest to manage without surgery. Excessive vertical growth, long faces, often with an anterior open bite where the front teeth don't meet. Historically, treatment involved high-pull headgear to try and hold the maxilla up, or bite blocks between the back teeth to intrude them. But honestly, the long-term effectiveness of these methods has been pretty disappointing. Part of the challenge is that vertical growth just keeps going for so long, well past adolescence.
So TADS again.
TADs are offering some new hope here too. You can use them to actively intrude the posterior teeth, push them up into the bone. That can help close down an open bite, allow the mandible to rotate forward and upward. We're seeing some success, but we still need more long-term data on stability. For the opposite problem, deficient vertical growth, short faces, treatments that encourage the back teeth to erupt more usually work pretty well and tend to be stable.
So summing up orthopedic treatment.
Yeah, I mean, it can work. It can resolve mild, maybe moderate discrepancies. Especially good for maxillary deficiency, pulling the upper jaw forward, particularly if caught early. Also maybe for correcting asymmetries that are getting progressively worse before adolescence. But for really significant mandibular excess, a lower jaw that's just growing too much. Trying to restrain that growth orthopedically, probably not justified, not effective long term. Clinicians really need to be realistic. Set clear goals, maybe a 6 to 8 month trial period. If you're not seeing significant skeletal change, you need to be prepared to say, okay, this isn't working, let's consider other options. Because the individual response is just so variable, we still don't fully understand the genetic or molecular factors that determine who responds well and who doesn't. More research needed there, definitely.
Okay, so if orthopedic treatment isn't enough or the patient is past their growth spurt, what's next?
Then you're usually looking at a choice between orthodontic camouflage or setting up for orthognathic surgery. Camouflage means using braces, maybe extracting some teeth, to move the teeth in a way that hides the underlying jaw discrepancy. It can work for mild to moderate issues, especially if the bite is reasonably good to start with and the facial aesthetics are acceptable.
But it's not always ideal.
No, definitely not. For class 2, if you pull back upper front teeth that are already normally angled just to hide a small lower jaw,
Right.
you can end up making the profile look worse, maybe a flat upper lip or a gummy smile. For class 3, camouflage is even harder. Many class 3 patients already have teeth that are naturally compensating upper incisors flared forward, lower ones tipped back. Trying to camouflage further can worsen this, lead to an unstable bite, and maybe make the chin look even more prominent, which might not be aesthetically pleasing. And it's absolutely crucial not to start definitive class 3 camouflage until you're sure growth is finished. Otherwise, the jaw keeps growing and the camouflage just relapses.
And open bites.
Camouflage for anterior open bites. Notoriously difficult and unstable long-term. Often require surgery for a predictable result. Ultimately, deciding between camouflage and surgery involves really understanding the limits of orthodontics and critically listening to the patient's and parents' concerns and aesthetic goals. It's a shared decision.
Wow. Okay, that was absolutely a deep dive.
Yeah.
Incredible journey from just a few cells becoming this complex face in weeks to these subtle changes happening throughout our entire lives. And then the really sophisticated ways we try to guide or correct it all. It's, yeah, a field full of wonder and clearly still lots of discovery happening.
For sure. Our understanding of the genetics, epigenetics, the environmental pieces, it's exploding, especially with genomics, molecular biology tools. But despite everything we know, it's really thought-provoking.
What's that?
The actual trigger. The precise biological switch or signal that initiates and directs your individual craniofacial growth. Its exact timing, its pattern, its rate. We still don't really understand that fundamental mechanism. It remains kind of poorly understood.
So even with all this incredible science, the core mystery of what makes your unique face your face, that story is still being written. How do you think that mystery affects how we view beauty, individuality, especially now that we can influence these processes so much? Something to think about until our next deep dive.